Welcome, welcome, welcome. Hi, everyone. My name is Cindy Batista. I'm an associate professor at the Egan School of Nursing and Health Studies. That's in Fairfield, Connecticut at Fairfield University. I'm also a neuroscience clinical nurse specialist, and that's at Yale New Haven Hospital in New Haven, Connecticut. And last but not least, I'm a nurse entrepreneur. I am the owner of Nursing Brains LLC. We provide nursing, neuroscience, nursing, continuing education, actually around the world. I'm so excited to present to you the top 10 nursing priorities for spinal cord injury. So, what are the top 10 priorities that a nurse should have in their mind when they walk into that patient's room who has suffered a spinal cord injury? Number one, I bet you can guess what it is. Airway. Absolutely correct. So I cannot stress it enough, especially, your cervical spine injury patients, especially C4 and above, they're going to need respiratory support. So when you do walk into that spinal cord injury patient's room, be sure you're looking at patency. So again, airway patency, are they in need of some type of ventilatory support? Make sure you're looking at the rate, the depth, and the pattern, right? Because we're talking about cord injury here. So all those peripheral nerves innervating those muscles, those inspirational and expirational muscles. So you want to consider airway all the way down to if someone has like L3 and above. Because again, they may have weakened respiratory muscles, so they're not going to be able to get that diaphragm up and down. Think about the breath sounds, because again, now we're dealing with what? Immobility. So with the immobility, possibly some kind of pneumonia may be brewing. So be sure you're looking at breath sounds. There's that cough strength and effectiveness, again, due to that innervation of those peripheral nerves into the respiratory muscles. Definitely monitoring. So what types of monitoring do? You're going to be checking your ABGs, trending, right? Trending your end tidal CO2s, right? How much are they retaining? Continuous pulse oximetry also. How much oxygen is being saturated? And then the secretion stagnation is huge with these spinal cord injury patients. So again, I just listing different techniques that you should have in your bucket list is the postural drainage, the tracheal suction, the manual cough support. And some institutions, and maybe yours, have the cough assist device. Some of us will use the abdominal binder. Again, that helps support that diaphragm and bring it up to a resting position. So airway, number one. I just want to share with you some of the evidence, what people are writing about, what people have found in caring for your spinal cord injury patient in regards to airway. Again, prevent hypoxemia. What are we dealing with here? We're dealing with a cord full of neurons. Neurons need oxygen to stay alive. So again, number one priority, what is that oxygenation content? So again, PaO2s greater than 90. The literature is also talking about early trach or early tracheostomies if indicated. So be a patient advocate, nurses. Think about this. The evidence is kind of strong out there. So you may want to bring it up to the team. Hey, team, is it time for a trach? And then again, that aggressive pulmonary toileting is necessary. All right, let's do number two. Again, assess. So the number two priority is going to be your neuro exam, your neuro assessment. Is our spinal cord injury patient getting better, or are they getting worse? Is that cord edema compressing on upper or lower levels? So cord, to me, motor, sensory. What is their motor assessment, and what is their sensory? Now, so with motor, it's strength, right? So again, move it, get it up. What do they do for extremity strength? Can they lift the arm up? Can they lift the other arm up? What about their legs? Can they lift those up? So, and then don't forget resistance. So again, it's that push against some kind of resistance. So push against me. So motor strength, be sure when you're assessing that you're using that movement against gravity and movement against resistance. The other thing to think about is tone, especially with a cord injury. Your spinal cord is your what? Central nervous system. So that central nervous system is going to cause what kind of tone? Spasticity. That is correct. So spasticity. So how do you treat spasticity? So again, it's kind of simple. It is. It's range of motion. So again, be sure you have that in your list of priorities or list of things to do. So take each extremity and provide that range of motion. Collaborate with physical therapy. This is what they do. So again, have some understanding that, again, the cord, central nervous system causing spasticity, best treatment for spasticity, range of motion. Once you have done that motor assessment, then move to sensation. So you need to ask them, do you have any numbness and tingling? No, you got to ask because you're not going to see numbness and tingling, right? So ask them, do you have any numbness and tingling in the arms, in the hands, in the feet, in the legs, right? And then move to light touch. So, right, just like touch. So again, always start proximal and then move distal, right? So am I touching you? Am I touching you? Am I touching you? That type of questioning you should be doing. And then again, it's really based on those dermatones, right? So again, just classic T4, nipple line, T10, umbilicus. Number 3, heart rate and blood pressure. Heart rate and blood pressure, right? So are they stable? So especially those T6 and above. So your T6 and above clients, they are unfortunately not going to have any sympathetic tone. So they'll all be vasodilated and they'll be bradycardic. So you're going to be dealing with bradycardia and vasodilation, all right? So blood pressure is the key. Again, the evidence, the guidelines say mean arterial pressure is greater than 85, especially during the first 7 days after injury. So again, is everybody good with blood pressure? Vasodilation, fill them up, tighten them up, fill them up. So, right, you're going to give them volume resuscitation, and you might need to add a vasopressor. 2 conditions occur with your spinal cord injury, so be sure you're looking for it. In the acute phase, be looking for shock, right? So that's that hypotension, bradycardia, poikilothermy. We're going to talk about a little bit about that. That's the temperature of the environment. They're going to take the temperature of the environment. Priapism, right? So your gentlemen, your male patients may possibly have this priapism. So again, to me, urology, call urology consult. Yeah, so shock. Now, the other thing is more of a chronic condition, and so this is a hypertensive crisis. So you want to be aware of that. You want to look for that. Again, T6 and above. So autonomic dysreflexia. So they're going to come in, they're going to be hypertensive. So the problem is pain. So don't immediately go, oh my God, they're hypertensive. Let me give an antihypertensive. You got to think, oh, this is a cord, T6 and above. Maybe they're in pain. What's the number one cause of pain for a cord injured patient? Bladder distension, urinary retention. So the way you treat this autonomic dysreflexia, most common, is straight cath. So in your minds, when you're caring for these patients, got to be thinking of these things. What are these priorities? What bradycardia, hypotension? Look for the shock. And then later on, if it's been a few weeks, look for this autonomic dysreflexia, especially T6 and above. That hypertensive crisis due to pain, more than likely urinary retention. Another common one is, can you think of one? Constipation. That's correct. So again, this is just sharing you what the literature is saying about the to fluid resuscitate. So again, crystalloids, you want to start with that, normal saline, 100 cc's. And then there is the vasopressor. So again, maintaining that mean arterial pressure. You know, there's so many there's a handful, I should say. There's a handful of vasopressors that we can use. I'm not going to mention any of them because they've all proven to be pretty much doing the job that they need to do. So again, it really does at this time. So if you're looking for a study, you might want to try that a little bit. Which vasodrip, which vasopressor will work the best. Okay, number 4, we're up to number 4. So again, once you have the airway under control, once you have the heart and blood pressure under control, and you know what their neural status is, again, cervical spine stability. Most spinal cord injuries have to do with the neck. So again, we want to keep those 2 vertebrae in alignment. So we want to do collars, right? So make sure you know the types of collars. What does your institution use? What type of collar has been applied to your client? Stiff neck, right? That's usually pre-hospital. Make sure you're removing that within 24 hours. Rigid, soft, make sure it's size appropriate. And I know all of you know collar care, right? Because big deal here with collars, pressure injury, okay? Cervical traction. So again, if the type of spinal cord or the injury, right, the spine injury that the client has, they need to stabilize the vertebrae. They may put them in the halo brace. So now you have to deal with pin care. And again, pin care is whatever the physician orders usually. And that is okay. That is okay. So whether you use saline, well, ideally saline is the preferred choice. You can see it right there. And then don't forget your skin inspection under the vest. Ideally, what should be happening here is early surgical intervention, right? So definitely within 24 hours, your client should go off to the OR and get their cord decompressed and their spine, the vertebrae, fixed and stabilized. Okay, number 5, temperature control. So again, especially if they're T6 and above, you're dealing with no sympathetic tone or no sympathetic nervous system. So they will take the temperature of the environment, right? We're going to call that poikilothermy, right? So be sure you're monitoring their temperature. Watch what the environmental temperature is, right? What is the appropriate, or make sure that, you know, they're comfortable in this room temperature, okay? I did put some evidence as far as temperature monitoring goes, or fever management. So the literature is pretty strong on, you know, the antipyretics, the NSAIDs, the Tylenols, the acetaminophen, the aspirins, and the ibuprofens. There, and again, I'm sure in your institutions you're doing either external cooling, and some of you may even be doing internal cooling for fever management. Number 6, okay, here we come to the home stretch. Mobility, right? So your cord, that's one of its major functions, is to move arms and legs. So if unfortunately the cord is broken or busted or injured, we've got to be moving our patients, or help them move, or educate them on how to move. I cannot stress it enough. PTOT, physical therapy, occupational therapy. Pull in your team, collaborate with them, get a good mobility plan. And then, of course, always early mobilization, right? That is so huge right now. So again, proper positioning, frequent turning, keep those vertebrae in alignment, use log rolling. And again, that slowly to get them to a standing position, that verticalization training. Again, depending on where the injury is, right, you're going to be doing that wheelchair transfers. Trunk stability is huge. I remember learning that from my physical therapist, right? So again, can they sit on the edge of the bed? How stable are they when they are just sitting up or sitting on the edge of the bed? You can see there on the slide that there's a lot of different stretching types of techniques, or types of treatments. So you can see that and look at that. You know, like the ultrasound, the shock waves, the TENS, to keep those muscles stimulated. So the big deal here is what? Thromboembolism prophylaxis, or venous thrombo, VTEs, right? So venous thrombus embolism prophylaxis. So again, we want to use both. So the evidence is very, very clear that you want to do both mechanical and pharmacological methods. So again, I'm just showing you the classic pneumonic compression devices, and then either your heparins or your unfractionated heparins. Okay, number 7. So we're up to pressure injury prevention. So unfortunately for our spinal cord injury patients, the mobility is gone, right? So a lot of them have this difficulty with movement. So that again is going to make them immobile. So be sure you're using an evidence-based pressure injury screening. A lot of people will use screening tools. Be sure you're regularly inspecting the skin, because remember, a lot of them can't feel. So then they won't feel that pain or soreness like us. So again, avoid extended periods of immobility. There's always this thing, pressure relief, especially if sitting in the chair. So there it is, provide pressure relief. So whether you're using a mattress, turning, you want to watch for moisture. Oh my gosh, moisture is also a not good thing, right? That totally breaks down the skin. And then food. Oh, I love the food. Nutrition, adequate nutrition to keep that skin healthy. Now, evidence-wise, so risk assessments every shift, it's well documented. Cervical collar issues. So again, pressure injury under it. There's always the chin. They always struggle with the chin and pressure and what do I want to say? Like abrasions, or that the movement of the collar against the chin area. So pressure relief devices. So again, pull in your special mattresses or heel lift devices. Turning schedules, make sure people are familiar with those. These are, I think this is a good idea. Sometimes I think we forget, but the prevention dressings. So I don't know if your institution has that. I don't know if that's part of your pressure injury prevention bundle or protocol, but you may want to look into that, or be sure to remember to use that, especially on the sacral areas. So use those prevention dressings. They do work well. And then last but not least, oh my goodness, incontinence barrier creams. So right from the get-go, apply some kind of barrier cream in the perianal area. Catch it before it breaks down. Prevent that excoriation. Okay, so pull out. I can't imagine that wherever you work, they don't have some kind of incontinence barrier cream. So get on that. That's what I say. Get on that. Okay, we're up to number 8, so a couple more to go. Pain. So pain management. So pain, again, assess pain, ask them about pain, use these standardized pain scales. I can't imagine, I know all of you know your different pain scales. And again, think about pharmacological intervention, and please don't forget non-pharmacological treatment. So pharmacological, again, treating the pain. Don't forget, our cord injury patients have spasticity, may be the cause of the pain. So the opioid might not work so good for this spastic pain. So you may need to pull in an antispasmodic, right? So maybe some baclofen. Now, the other thing to think about with these cord injured patients is neuropathic pain, because not only have they injured the cord, but the peripheral nerve. So that those peripheral nerve injuries respond well to neuropathic pain medications, such as the pregabalin, gabapentin, amitriptyline. So think about, what is the source of their pain? Is it because of the lack of tone or too much tone? Or is it because of peripheral nerve pain? Okay, so, or it could be actual bone pain or cord pain. So now, non-pharmacological, put some ideas, use positioning, use distraction. That's my favorite, so distraction. So find out what they like. What do they like to do? Is it the TV? Is it the music? Is it, and then look, I'm looking at relaxation, right? Relaxation. So do they need a massage? Do they need some, maybe acupuncture, or, these complementary type treatments may work really well for these spinal cord injury patients. Number 9, so we're getting down to the top 10 here. So number 9 is the bladder and the bowels. Okay, so bladder and bowels. So bladder, the usual issue is urinary retention. So again, implementing some kind of bladder management program. So you would want to either refer to your institution's bladder management program. You can easily review the literature. There's several pieces of literature and evidence on what works best. Ideally, it is that intermittent catheterization every 4 to 6 hours. Okay? So that's urine. Now let's go to the bowels. So the stooling. So again, you want to be looking at bowel sounds. Ideally, in the first few days, a lot of cord injured patients will have a paralytic ileus. So you want to be listening. If they have no bowel sounds, you want to kind of bring that to the team's attention, right? So no bowel sounds. Hello. So be thinking about that possibility of a paralytic ileus. So like no peristalsis going on there. And then good old constipation. So I'm sure that several of you in your institutions have these bowel management protocols, or these preventing constipation protocols. So again, I just listed what was pretty common in the literature. So it's really volume, fluid, high fiber. Cord patients, spinal cord injury patients respond pretty well to digital stimulation, right? Stool softeners, suppositories. So again, be sure you're looking at that. Last but not least, the number 10 priority. So once you've gotten their airway under control, once you've gotten their heart rate and blood pressure under control, once you've got their mobility under control, once you've got their bowels and bladders and you've got their skin under control, you need to think about sexual dysfunction, conversations, and psychosocial. I really don't want to say, I mean, last but not least, these two are very, very important issues to me as a nurse that we either bring up or we wait for the right moment. A lot of times our clients will bring this up, right? A lot of times, at least let's focus on sexual dysfunction. So sometimes, right, you got to wait for the readiness, wait for the comfort level. Comfort level to me is going to come with relationship. What type of relationship do you have with your client, right? Or do they have that trust? Do they have that comfort level to verbalize their sexual concerns? Okay. So the big deal is, privacy. I'm not sure that we need to be screaming and shouting and discussing sexual concerns. Definitely respectful, dignity, positive, right? Encourage experimentation is key, right? And offer counseling. Sexual dysfunction, for me, I have little expertise, but I would pull in my occupational therapist. So I'm not sure a lot of you know that, but occupational therapy, part of their curriculum, part of their expertise is sexual dysfunction. So for me, spinal cord injury patient, if I get the question, if they're going to ask me, will I be able to perform? What will my performance be like? When will I be able to have sex? Or when will I be able to have, when those kinds of questions are coming up, you have to be honest and truthful. Sometimes I say, I don't know. Sometimes I say, I hear your concern. Let me call in some experts. So I would be calling in, again, occupational therapist. And a lot of your rehabilitation centers, they actually have sexual dysfunction therapists. So, you want to get connected, or you want to know your resources. I guess that's a big thing that I want to push there. Okay, so sexual dysfunction. And then last but not least, psychosocial, right? This is a huge change, right? This is a sudden event, right? This is, again, look for the fear, look for the anxiety, watch the depression, watch for it, monitor for it, assess for it, right? Look for signs of grief. This is a life-changing event. They've got to mourn the loss of who they once were. So think about this. Set it up for your client. Understand that your client is going, look at these emotions. I don't know. I feel as a nursing, this is what we're best at. How can we help our clients with their fear, their anxiety, their depression, their grief, their loss? Right? So be there for them psychologically and emotionally, right? Remember to repeat information, right? This is a sudden event in the beginning. There's just so much going on. So, repeat, constantly say the same thing over and over again. So that's client focus. What about the caregivers, right? So not only as nurses do we care for the client, but we also patient, or we also talk and help the caregivers. Okay. So they too are going to have some issues, especially coping. So really start assessing their coping skills. Do they have coping skills? What can you help them with? Problem solving is huge. So, what are their problem solving skills? So, sometimes you kind of got to work on that with them. And then, last but not least, and I think this is a great way to end this presentation, spinal cord injury clients and caregivers, you, the nurse, we need to create this trusting relationship. We need to be honest with them. Sometimes honesty with this type of client can be painful. Be positive. And please, please, empathetic. I just want to say thank you so much. Those are the top 10 priorities. You, the nurse, when you walk into that client's room, these are the priorities that you should have in your mind and be sure to check off every day. Thank you so much. It was a pleasure to present to you. Take care. Bye-bye.